Hello and welcome. We're going to go ahead and get started today because we have a lot to cover for you. Even though a few of you are logging in, we are recording today, so if you missed any part of this, you can review it later in its entirety. My name is Megan Campbell, and I am the Marketing Director here at Casamba. And again, I just want to say thank you for joining us for the second part of our Regulatory Update webinar series, which focuses on the impending RCS. A couple of housekeeping technical items before we get started. Since there are a lot of you with us today, your lines will be muted, but we do want this to be somewhat interactive, so we welcome your questions and we'll answer as many as time permits at the conclusion of today's broadcast. So to send a question, you can use the questions window or the chat window, which should be located to the right of your screen. If we, for some reason, can't answer all of your questions, we will make sure to have somebody from our team follow up with you to make sure we get an answer. We are, again, recording today's broadcast, and we'll send you a link via email, most likely tomorrow afternoon, that you can review and share. So a few words about our company, for those of you that aren't familiar. Casamba is the largest provider of software and solutions to the post-acute therapy space. Through our Smart Direct Bill Therapy Source, Rehab Toolkit, and HealthWise solutions, we now serve over 12,000 locations nationwide, including outpatient clinics, home health and hospice agencies, and of course, clinicians in skilled nursing facilities. So I'd like to introduce today's expert and host. Jane Moffitt is a registered nurse by training with over 20 years of experience in the acute and long-term care settings. Throughout her career, Jane has helped healthcare organizations design and apply technology solutions to address critical needs and challenges that are faced in their facilities. As our Chief Product Officer here at Casamba, she uses this knowledge to help us build and deploy solutions that add real value to organizations in the post-acute continuum of care. So with that, I am going to turn it over to Jane to officially begin part 2 of our regulatory update. Jane?
Thank you, Megan, and thank you everyone for joining. Today is the second part of RCS, and we're going to start by doing just a quick review of the proposed RCS rule. We're going to do that fairly quickly so that we can get into a couple of deeper subjects, a case study in major joint, and also more detail on the Casamba proposed solution. So we're going to just jump right on in with our quick review. So how is the proposal supposed to work? The proposed RCS payment model would take MDS data from the 5-day assessment, and we'll use that data to calculate 5 case mix indices. And those are a nursing CMI, a non-therapy ancillary CMI that would include things like medications, IVs, and so on. 2 therapy CMIs, one for PT and OT grouped together, and one for SLP by itself. Neither one of those therapy CMIs are using therapy minutes from Section O. And then finally, we have our non-case mix CMI. The sum of all of those CMIs are together used to calculate a daily rate. And it takes other variables, including urban, rural, and other geographic and wage index variables to come up with that final rate. Will be a per diem rate for the patient and will be applied throughout the patient's length of stay with a couple of idiosyncrasies that we'll discuss. CMS has proposed this model based on data that they ran from actual assessments, and they're assuming 4 things in the new model. The first one is that the patient population will be the same kinds of patients that we have been admitting and taking care of in the past. We will admit and take care of after this rule goes into effect. They are also assuming there won't be any changes in provider behavior. We will treat the patients the same way like we did before. They're assuming that the MDS will be coded the same way, and there is an assumption that the payment outcome would be budget neutral. When we look and compare the proposed model on the right with the current model on the left, there are some similarities. We have nursing case mix indices, the calculation for which is remaining the same. Therapy, though, has some major changes. We have our PTOT case mix, and that is not based on minutes at all, and our SLP case mix, also not based on minutes. Non-therapy ancillaries is a new addition, and then we have our non-case mix. Let's review for a second how PT and OT are calculated. Those values use three types of information together to calculate a CMI. It takes a clinical category plus a functional score and also factors in cognitive impairment. The clinical category is determined by 30 possible classifications. Those classifications fall into one of 5 clinical categories, and those clinical categories are listed here on the screen. And then, in addition to the clinical category, we're factoring in a functional status, and this is based on ADL self-performance scores only for transfers, toileting, and eating. You take the sum of those values on the MDS, and those together generate a score between 0 and 18. The higher the score, the higher the CMI or the reimbursement. And then the last variable that's factored in is cognitive impairment. In this case, we're either using the BIMS or the CPS scores. And in the case of PT and OT's CMI, the more impairment that our patient has, the lower the score, and therefore the lower the reimbursement. Interestingly enough, when we look at our clinical category, that diagnosis in I-8000A, there are more than 150,000 code pairs factoring back and forth between ICD-10s and DRGs. Looking to our next category list, we can see those 5 categories mapped out with the case mix index on the far right. So that CMI, case mix index, is a multiplier and gets added to other variables, urban, rural, geographic, and so on, to produce a dollar amount. SLP has the same kind of calculation as well. 3 variables, different ones though. We have our clinical reason for stay, where we have 18 possible classifications, and those classifications can only fall into 2 categories for speech. Is it an acute neuro, or is it a non-neurologic diagnosis? After that's determined, then, we reach into the MDS again to check to see if we have a swallowing or altered diet flag. And in that case, we have 3 potential combinations. We have both a swallowing deficit and an altered diet, either of those or neither of those. And then finally, we reach back into that comorbidity and cognitive impairment area within the MDS to determine if we have both a speech comorbidity and cognitive impairment, either a speech comorbidity and cognitive impairment, or neither of those. For those SLP comorbidities, the proposed rule did list what those would be, and the items that are starred, that indicates that it is an area in the checkbox portion of Section I where we would find this, as opposed to within I-8000. And this table represents the clinical categories on the far left, our flag for swallowing disorder and or diets, and our flag for comorbidities and or cognitive impairments. On the far right, you can see that case mix index, and again, that's a variable that gets multiplied by other factors to come up with actual dollar amounts for reimbursement. CMS is also proposing that there would be a per diem adjuster, and that per diem adjuster hits our PT and OT CMIs, and it also hits our non-therapy ancillary CMIs. And for PT and OT, this is the way that it was proposed, where days 1 through 14, we would receive an adjustment factor of 1, basically 100% of the dollar amount. And then every third day after that, throughout the entire Medicare stay, we would go down a percentage point, if you think about it that way. So we'd multiply 0.99 of that dollar amount from day 15 through 17. Days 18 through 20, multiply 0.98. So we would reduce that dollar amount throughout the length of stay for PT and OT. There are some additional factors in here. It's a 5-day assessment that we use to determine these CMIs and CMGs throughout the length of stay. Unless we met the criteria of a significant change in status assessment, that kind of assessment could reset the CMIs and CMGs. And finally, there are provisions to collect some data on the discharge. And that data has been proposed to be Section O. Unsure at this point how in Section O, but if they use the current way we're collecting Section O and change those values to collect from the start of the Medicare stay through the end of the Medicare stay, then it would, rather than the observation period of a typical MDS, which is previous 7 days. The proposed rule also suggests that concurrent and group would be limited to 25%. And we do not know how that is going to be determined either. Would that be throughout the whole Medicare stay, or would that be for a typical 7-day observation period, which is the current practice? And then finally, there is also an interrupted stay policy. And in this case, if the resident discharges from our facility and then returns back within 3 calendar days, we just pick up where we were before, and we don't reset and do another 5 days. So this is similar to what we call our skip days. If the patient did get discharged and came back in and met the criteria for a significant change in status assessment, however, you would complete one of those and potentially after the readmission, then reset the CMIs. And then again, there is a presumption of coverage that has to be met. So the patient still has to meet the criteria for skilled. And that is would potentially stay the same as it is today. So we've got some identified challenges then when we review, in particular to our sector, to therapy. First of all, both PT and OT's clinical categories and also speech's clinical categories are using the very same field on the MDS, I-8000A. Prior to this proposed method, that field on the assessment held no particular importance. Second challenge is those diagnoses are mapped back to DRGs. And the notion of a DRG in a post-acute setting, in a SNF setting, is a new one. And so just thinking about how that would work is a major challenge. Of course, this proposed model didn't take advantage of any of the new areas of the IMPACT Act where we're actually looking at outcomes. And so that's a little bit, I think the industry is perplexed that CMS didn't take the opportunity to enhance a payment model towards outcomes, because that's been a discussion for several years. In our non-therapy ancillaries, our HIV/AIDS adjustment has been significantly reduced, so there are factors that relate to reimbursement from those high-cost meds. And then finally, it looks like we're still going to be reporting minutes at the end of the Medicare stay, which means that the industry is going to receive scrutiny on practice, and CMS will also have high visibility to any change in practice on how we treat these patients. So what could go wrong? Well, let's go ahead and start with I-8000A versus Section I. We call this here at Casamba RCS roulette. We're going to just take a quick example of a major joint case. This is a patient that underwent an elective hip replacement and also comes to us with some other problems, much like all of our population. So he comes to us, he had a hip replacement, he's also had a TIA, he's got a pacemaker, he's on some medications, on antibiotics. From a functional deficit point of view, he needs quite a bit of intervention to make a difference on those functional deficits. He's a high fall risk, and we'd like to DC him back to his prior setting. Based on all of his comorbidities, you know, he really could almost fall anywhere, and this is very typical of the data that we here at Casamba have reviewed. What clinical category could this gentleman potentially fall into? Of course, the obvious one is major joint. That would provide for us the highest CMI and therefore the highest amount of resources that we would need to take care of this patient and get him back to his previous state. But he could easily also fall into other orthopedic. He's got a diagnosis of arthritis that actually led him to this hip replacement. He's got a TIA, so there's some acute neuro, and he's got lots of other medical problems that could easily place him into medical management. And if you look down at the bottom, he could range out from a CMI, you know, as low as 1.36, as high as 1.73 when we dig into and look at him with his comorbidities. And of course, we're basing it all on I-8000A today, and that's what the proposal would do. But where's that major hip today? It's over here in the checkbox area of Section I. So in the proposed model, the way it would stand today, we'd never hit this. But let's just think for a second, you know, about the intent of this. And I think me and others in the industry, we don't believe that CMS meant for us to miss this. And if they are going to use Section I, we think that they'll fix that and they'll advise us to list diagnoses in I-8000A that we may also have already considered in the upper portion of Section I. So we're going to kind of go with that assumption. Even when we do that for this gentleman with this hip replacement, we have more problems to think about with the proposed model the way it is today. You know, how do we actually get to where we want to be from a CMI for PT and OT for this gentleman? So when we go back and we make an assumption then that we are going to use I-8000A, well, then how's that going to work? All right, so we know that we need, in order to get our gentleman into this clinical category of major joint replacement, spinal surgery DRGs, okay, we're going to have to fall into a DRG of 469 and 470. And we know that based on the table that was in the Acumen report that mapped clinical categories back to DRGs. They gave us that data to work with in the report. And so we know that for our gentleman to map back to a major joint replacement clinical category, he's going to need to be in 469 or 470. Great. That's good information to have. How do we get him there? The information that we have, that the industry has, that maps ICD-10s to DRGs is available online from CMS. I'll show you where the source is. But it's going to be challenging. First of all, we're not in DRG mode, but secondly, the DRG to ICD-10 for major joint replacement, the ICD-10s are on the far left. There they are. And these are all surgical ICD-10s. There are no other ICD-10s in the current ICD-10 to DRG mapping that would place a patient into these DRGs. And just so you can see that for yourselves, here's the screenshot from CMS. So our DRG of 469 and 470, there's the list right from the website. And you can see that these are all operating room procedures. these procedures, diagnoses, they don't typically make it down to us. So we have some major challenges with the model and the way it is today, even when we try to work backwards. I believe, and I think others in the industry do believe, that after we presented our comments back to Medicare, that this doesn't really follow their intent either, and that they will have to fix this as well, because we really are making an assumption that the resources needed to take care of this patient, that the data is going to be there to classify the patient in the correct clinical category to follow what we believe was the intent of the Acumen work. Interestingly enough, if you read through the Acumen report, they talk about using I-8000A to determine DRG and therefore clinical category, but the actual data that they used was claims data from the acute stay of the patient. So they were using acute DRGs that would have had these diagnoses on that acute claim. However, they sort of transformed it into our post-acute SNF setting where these same diagnoses would not be used. So it's kind of an interesting take on it, and we've done a tremendous amount of data analysis working backwards with all of our major clinical categories that we typically see to see what diagnosis exactly would help you fall or would make you fall into this DRG. And primarily the diagnoses that we use in our setting would make you fall into medical management. We don't believe here at Kizomba that that was the intent of CMS, so again, I'm just going to reiterate that as this model is refined and we begin to get more data tables from Medicare, I and others believe that this will be fixed, but this is a concern. Now let's say that it is fixed then, and we are able to better understand and have a clearer picture of the diagnoses typically used in our setting and map those back to DRGs and map those DRGs then back to clinical categories. We still have to be in a position to accurately report those diagnoses. And so diagnosis coding is going to be very, very critical. So this brings us back to this RCS roulette. In the data that we modeled, much like the example that I showed you above, our gentleman with multiple active diagnoses could have fell into 4 of the 5 categories by virtue of whatever diagnoses we happen to place in I-8000A. And if we put him into a clinical category that didn't provide the resources to take care of this patient, then we would be challenged to provide him the same kind of care that Medicare is saying they're expecting of us pre-RCS versus post-RCS. So this is a really important point. You know, and again, more than half of the patients would fall into medical management based on the current diagnosis to DRG mapping, which is also a concern, and I do not believe was the intent. And I keep saying I don't believe it was the intent because they used the hospital DRG to determine the impact to the industry and the impact on payment. And that hospital DRG did more accurately report what that patient was actually seen for, even though the diagnosis that we're going to use in our setting, it would have placed the patient in a completely different DRG. And then again, looking at those potential differences, just to illustrate differences between medical management, major ortho, major joint. These are large differences when you use them as a multiplier to determine reimbursement. So that's a good review of RCS. It was a fast one, and if you want a more comprehensive, detailed review, I recommend, if you haven't already, that you access Lesson 1 and listen to that. I think it's important to refresh before we start the plan. And so the balance of the presentation today is to really talk about what we're going to do to help you kind of weather this change, be prepared for this change. In addition to doing our series on RCS, we're actually doing real work inside Casamba. And the first piece that we have done is we have reverse engineered the grouper, and we're providing a way for you, our partners, to upload your current assessment data and have that data analyzed. We're going to run that through an algorithm, and I'll talk a little bit more about that. And we're going to look at actual placement of I-8000A versus other diagnoses that are already part of the patient's profile. If, you know, as this model evolves and also when it actually becomes into effect, then we will help you use that CMI to guide your clinical team through proper planning or typical planning of that same kind of patient, so that we can ensure that our overall practice doesn't change, because we know, because CMS indicated it, that they don't expect provider behavior to change. So they're expecting a patient who had the same kind of profile prior to RCS-1 to be treated the same as a patient with that same profile after RCS-1. And then, of course, from a contract therapy point of view, many of you on the line are contract therapy providers, you know, engaging in real dialogue on how to partner with your facilities where you're providing services from a contract therapy point of view. So the first thing that I want to talk about is our Mds Upload Tool. And this is a permission-protected screen that will allow you to upload submission files. We're supporting any software. So whether that submission file was created from PCC, AHT, Matrix, Pathlinks, you know, any of the MDS partners that our facilities are using. I'll show you how that works in just a second. We're supporting a single or a batch upload, so if you have a whole bunch of assessment files that you want to upload, let's say you want to have us analyze a quarter's worth of data, for instance, you'll be able to get those uploaded very quickly. As those MDSs change, and I do expect them to change as this model evolves, we will be adding dynamically and modifying columns, and that's an important feature, because we don't want to have to go back and re-engineer this tool, and we fully expect assessments to change. The great thing is that you'll be able to use it now for your current patients or any historical data if you want to really look at your impact. And then this will end up in a reporting database. So here's how it works. You'll upload those files, and there will be a service that will wake up and look for new files every 24 hours. It'll pull those files down and parse those hundreds and hundreds of MDS fields into a database. And it will also reach into your smart server and find the same patient. And this is an important part of this, because we want you to be able to compare new model to the previous model. And then there'll be a reporting service that will run against it, that data, and the first run will look at that exact MDS diagnosis in I-8000A, and then we'll run it again against all of the diagnoses in the patient's profile. And then finally provide you the ability to measure impact against payment. We believe here that it's really important for you to have an understanding of your impact. Medicare did provide some data on that, on what they believe impact will be. We don't believe that that was accurate, because their report indicated that as many as 25% of the assessments were not factored in when they went through those calculations. So we think it's a great idea for you to take a look at your own organization, and this provides you a way to do that. So when can you do it? All right, we're going to support two ways for you to do this. The first way is for you to SFTP it. Any of you in our larger organizations are familiar with SFTPs, and this is where you can, through a secure file transport protocol, drop batches of files. But there's also an easier way for you to do this. If you don't want to do massive SFTP from an IT perspective, we are providing a permission-protected screen from right inside of Casamba where you can upload from there. And then we are continuing to refine the reporting. We're going to allow uploads to happen immediately, and as we're refining the reporting, we'll make those reports available to you beginning early December. And we will be able to give you your CMIs and CMGs for all 5 categories, not just PT, OT, and speech, and then allow you the ability to load up comparison data, and we'll walk you through how to do that using the urban and rural calculations. And that will actually allow you to see your financial impact. So it's important that you see CMGs and CMIs, but also understanding the financial impact of actual reimbursement, I think is really where you're going to see a lot of impact. And one more thing to really remember, this model is going to evolve. There are so many flaws in the data tables right now that when we in the industry dig in, we do not believe it was Medicare's intent. We believe it was test and proof of concept data, but actual tables are going to be refined to meet the intent of what we think Medicare had. And so we will make changes to our model as those refinements are published out to the industry, and we will rerun it against assessments that you may have already uploaded so that you have up-to-date, accurate information based on whatever information the industry has available to us. So here's what it looks like. It's a permission-protected option under the Facility tab inside of SMART. And we will work with you to determine who that will be. It uses actual XML files that are submission files. And these are full MDSs. It'll take any naming convention, and you can also multi-select. So this is the easier way to do it. The SFTP requires IT intervention, and so larger organizations, that will be an easier way for groups like that to do, where they've got large batches of MDSs and they just want to pull those files over. They're familiar with SFTP protocol and the tools needed for that. But for even larger organizations, this is a great option for you to multi-select and pull it into the database. And then it will be in the reporting database ready to go and ready to use and reuse potentially as we refine the data needs around these MDSs. So what kind of reporting are we going to give back to you? All right, first of all, we're going to give you back that raw data. We know that many organizations want to look at that data, and it's almost impossible to do in an XML. We're converting that XML into more of an Excel type look in those SQL databases. So all of our partners will have access to all of that raw data. We're also calculating all the CMGs and CMIs for all categories, not just PT and OT and speech. We're matching back to actual patient data. And we're going to lay that patient data down so you can see the length of stay for each of those patients, what the RUG score was for each of those patients, and the therapy component potentially for those RUG scores if you have loaded that into our software. If you haven't, we'll show you how to do that. And then that will allow you to compare reimbursement, looking at reimbursement in the current model and for PT, OT, and speech reimbursement in the proposed model. And then finally, that ability to rerun as this model changes and is refined, and more importantly, as the data tables that we have that were used to calculate the model change and are refined. Because it's not just I-8000A, but it's all the supporting mapping back, diagnosis to DRG, DRG to clinical category. We believe that those actual data tables that have 150,000 rows in them will be refined to better reflect what we believe the intent of this model is. So that is what we're going to do. Meantime, provide you the means to look at your current data, your current practice, see what your impact is, and really be able to actually measure that impact down to the financial impact potentially. Now, what are we going to do, though, if we actually come to a point where this is our payment model? Because this is a big difference from what we are currently accustomed to today. In today's model, remember, we have a patient, they come into our therapy department with orders, we evaluate them, and we set up a plan, and that plan is based on a frequency and a duration and an intensity that the evaluating therapist feels is appropriate for the patient. Using that information, then we lay down the amount of minutes and days and so on that we need to see the patient. And we look forward because we're in a prospective payment model. Throughout the patient's stay, we're constantly reassessing that, and we're re-reporting those minutes back on change of therapy OMRAs to reflect the patient's increase in intensity or decrease in intensity. Again, though, in a prospective model. Those MDSs, they're typically collected in a leisurely fashion, if you will. And in particular, the 5-day assessment collected at some point after day 7, where we have an observation period to look at, and then are potentially submitted at some point after that, between day 14 and on. And if this really does happen, we are in a position where we have got to actually know ahead of time, and we don't have Section O to help us out. So we are going to help you put the puzzle together because we feel like it's really important that you have visibility to the resources available to you and that you understand what those resources are. And so here's what we're going to do. We're providing a tool where you can collect data on pre-admission or admission, and you will not have to wait for the assessment to be collected. And this data will have, this tool will have all the data elements necessary to collect not just PT and OT, but also, and of course speech, but also the other areas that would affect the CMIs and CMGs, so all 5 areas. We know that some of our partners are going to be very interested in therapy, but we have other partners who are fully embedded in the facility and may want to assist the facility with a collection tool, even on pre-admission. So you have an idea of where this patient's going to fall if you're pre-admitting in the acute setting. And this, of course, will evolve. This is the prototype of the tool today, but as the model evolves, the tool will evolve. It will be a web-based tool so that you don't have to actually have our software in order to use it. And that's important if you're out in the facility, for example, in pre-admission mode, or if you're on the floor. And if the patient indeed does get admitted to our software, then we will be able to import areas right into your Casamba Smart Plan of Care where that makes sense. What we will do in addition, though, to collecting this is really guide the clinical team into what is the likely diagnosis for I-8000A based on the clinical picture of the patient that would provide us the resources to take care of this patient in the way that we believe CMS intends. And I'm going to go back to the data that CMS used. They used DRG data from the acute claim. So that was actual hospital data from the acute claim to determine DRG. And in the case of my example, our patient would have fallen into major joint. But as we work through this then in our setting, we are going to have to figure out what diagnosis is appropriate to make the patient fall into the clinical category that would apply resources appropriate to take care of this patient. Again, going back to the fact that CMS used the DRG from the acute claim. So we're going to help determine what that diagnosis would be that would map back. We'll also display comorbidity diagnoses because remember, for speech, we also need those. Those determine and in fact increase the resources that are allowed for the SLP-CMI. The absence or presence of these comorbidities are a really important piece. And then, of course, we're going to display all the CMGs and CMIs for all 5, as I mentioned before. And if we do indeed bring this patient onto caseload, if we have orders, then this data will flow in and be supportive in your plan of care. So we're going to, in addition to having this tool on pre-admission and admission, of course, if you don't use that tool, you'll still be able to determine that right inside the plan of care and establish, track, and monitor CMIs and CMGs right inside our plan of care. And we will actually use those CMIs and CMGs throughout the patient's length of stay to help you track and monitor best practices through the planner. Going back, of course, to what CMS intent was, that the practice will not change. The patient we treated before and the way that we treated them and the outcomes that we got, there's an expectation that we would have similar treatment and outcomes in the new model. So we want to also provide you some guidance and visibility to how this same patient was treated prior to the new model. This way you can look at your data, benchmark, and do education and training, and also understand risk from a post-payment review. If there is a huge change in provider practice, then there is a very large risk in a post-payment review. And if there's a huge change in provider practice and we don't provide the amount of therapy that was factored in to the calculation from a CMG and CMI, we also run the risk of a reset of the CMGs and CMIs, much like we are seeing in our Part B codes, the missed value codes. So that same kind of risk would potentially occur because if CMS finds that we are practicing much different from what they thought, then they will call those misvalued CMIs and CMGs, and they will drop those down. So pulling all those data elements right into Casamba, comparing length of stays for patients, you know, how long did we treat them, what was the intensity, being able to have that data right away on admission, looking at and comparing therapy utilization within your own organization and also outside in the industry. And then the last thing I want to touch on is, what about contract therapy? Because there are some major changes to contract therapy. Our current Medicare Part A contract therapy methodology, at least from a per diem RUG standpoint, really is obsolete in this model. We have other models, though, that potentially work today where we wouldn't have to make any changes, and that would be our level contracts, set levels, and level by minutes contract, per minute contract. But we also believe that the industry will look to determine and come up with new types of contract therapy methodology, perhaps a risk sharing or a CMG or a CMI daily. And so what we want to do is we want to hear from you. And Megan is prepping an invitation to all of our partners to come together and have some frank discussions on realistic contract therapy methodologies through a community think tank. And I propose this at our conference to whet the appetite. This will be coming this next week, and we'll be starting to meet regularly with our partners because we really want you to be able to make a difference to your facilities in many ways. The first way, of course, is clinically, being a facility partner able to collect data about patients go into those patients and, one second, let me, and go into your facility meetings, your stand-ups, understanding what resources are needed to treat this kind of patient, how this patient was historically treated, what the CMG and CMI should be based on the patient's clinical picture, discuss placement of ICDs and comorbidities, but also looking at it from your point of view, from a reimbursement point of view, being assured that you would have the resources you need to provide the same kind of or comparable treatment to the patient to ensure patient outcomes and also mitigate the risk of a post-payment review. Fiscal stewardship is really a subject that has to be thought about in this model, making sure that we do have the resources necessary to treat the patient in the new model, and how does that translate back to contract therapy. So think tank we'll get some information on next week. We will, the upload button inside of SMART is getting deployed next week after end of month is done, along with complete release notes, just to walk all of our organizations through how to upload from inside of SMART. And there'll also be some instructions for those larger organizations with an IT presence who want to do a batch upload through SFTP so that we can get started on giving you back your data. And, you know, I think planning is a major piece of any type of change. We plan, we continue to look at what we're being presented with, and we refine, we look at our data, that helps us prepare, and all of that will really help us perform. And what we have to remember, the performance is, you know, it's the patient that we're treating here, and providing the patient what they need to get better, those skilled services, those outcomes. This is really what we're here for. So when we look at a payment model, we have to fully understand from a resource perspective how it is that we're going to accomplish what we're supposed to be doing for this patient, this holistic care that we're providing in our skilled nursing facilities. And I didn't leave very much time for questions. I apologize. Megan, do you think we have time for a couple of questions? Do we have any questions queued up?
We do, and just as a reminder, if you do have a question for Jane, send it through the questions window, and if we can get to it now, we will. If not, we'll have someone from our team follow up with you with an answer. So we do have a few questions, Jane. The first one is, when is this projected to roll out to the industry?
It's been projected to be as early as next October, a year from now, but I don't believe that that is feasible from an MDS data and billing perspective. And I think most people in the industry would agree. Whenever there are major changes to an MDS, it takes CMS quite a long time to get their grouper going. To not just to be able to upload and process those data elements, but also from this point of view, we actually have a whole new methodology for per diem, and it's a little bit more complicated because of the adjusters for PT and OT and also for the non-therapy ancillaries. So while they might have been able to handle the new per diem rate, this whole tick down where we're multiplying by a percentage and moving reimbursement down is complicated and not something that's at all factored into the current CMS billing methodology. In addition to just the practical application of a new MDS, new data elements, and new grouper, of course, we have some major flaws in the data tables that we have fleshed out and brought to CMS's attention. And so they're going to have to do some big work on ICD-10 to DRG mapping, for instance, in order to get those mappings in a position where the patients would fall into the appropriate clinical category. And so those data tables, they exist, but they're they're not working for this model, and so there's a lot of change that has to happen there. Plus, of course, all of the comments about whether or not this is even the right road to go down from a reimbursement, from a clinical appropriateness model. So those three things together make me feel strongly that we're not going to see this next October. If we did see it next October, we'd get a proposed final rule, and then, sometime in the spring, and then a final rule in July. For coding, October, it's not really realistic. However, October 2019 has high potential. Next question? Or Megan, do we have time for one more?
We do. I think we can squeeze one more in. So is there an extra charge for Casamba clients to use the MDS Assessment Analysis Upload feature?
No, there is not.
I knew that would be an easy one. So let's squeeze in one more. So where will you pull the diagnosis from to run and provide comparison reports?
In two places. We're going to start by running it from exactly where it is in I-8000A, because we think that that's an important thing for you to know. And then we're also going to take all the diagnoses in the patient's profile, and that would be diagnoses that are checkboxed in section I above I-8000A, and also all the diagnoses in I-8000A through J, assuming that those are the patient's profile. We're going to run those through again and tell you what the likely appropriate diagnosis placement should be in I-8000A. Because remember, the patient's the clinical picture is the same, and prior to this new model, what ended up in I-8000A was just by roulette. So we're going to give you two values. And that way we do believe that there's going to be appropriate importance placed on diagnosis placement after this model goes into effect. So you would take the patient's profile and you would put the appropriate diagnosis in I-8000A. So you'll get both values.
Okay, as a follow-up to that one,
go ahead.
If you can squeeze it in,
sure,
will it be to our benefit to enter as many ICD-10 codes as possible?
The instructions in that area, in I-8000A through J, talk about the patient's active diagnoses in the last 7 days. And as a provider, you need to follow the instructions for that section of the MDS. And Leanne, do you have any take on that at all? I know you're on, and you're a RAC. You have your RAC certification. Would you agree with that?
I would. You certainly have to follow the instructions specific to that section, and I think that hasn't been a focus as far as the placement, which certainly will come into play going forward. But the instructions, to our knowledge, aren't going to change, so we have to continue to follow those.
Thank you. And I want to thank all of our participants. We had wonderful attendance here, and that's great. We're so happy to be your partner and have us on. And for folks from the industry who are interested and are not already a Kizomba partner, we'd love to hear from you as well if you're interested in talking more about this solution with us. And with that, I'm going to hand it back to Megan so she can do some mop-up from a housekeeping point of view.
Thanks, Jane. As Jane mentioned before, we'll soon be launching our community think tank. So be on the lookout for some more information on how to join that and the sessions that we'll have that coincide with that. For today's broadcast, you should receive an email tomorrow that will have a recording as well as any ancillary materials and some links to the previous session we had a few weeks ago for your review as well. Again, we thank you for joining us. If you had a question and we weren't able to get to it today, we'll be happy to have a Kizomba team member follow up to make sure we get an answer for you. So again, be on the lookout for those emails, and we'll give you just a couple of minutes back in your day, but we appreciate the time you spent with us and hope you found it valuable. Have a great day, and we'll see you soon.